Okay. I guess it's 11, well, for me, it's 11:31. For you guys, it's probably 9:31. But good morning, everybody. Today is our GlomCon PACE conference, which is we do these sessions on second Sunday at 9:30 a.m. California time and 11:30 my time, which is Chicago Standard Time, and then 12:30 Eastern Time. These PACE conferences are for patient care and patient and caregiver engagement. I am Dr. Tripti Singh. I'm one of the nephrologists who works at University of Wisconsin-Madison and see patients with kidney disease, specifically with glomerular diseases. And I'm very interested in patient education. That's one of the focus areas that I love doing that and enjoy doing that as well. These PACE conferences, like I said, we do it once a month. And with me is Tony, who helps run this meeting, and I'll let Tony kind of introduce herself.
Oh, hey guys. I'm Tony. I'm part of the GlomCon PACE, so it's good to be here. If you guys have any questions or anything, you can always put it on the chat. The link or the box during this meeting. So
Rika, we are still seeing your screen, so if you can put the disclaimer thing up. So Tony is one of our patient. Can you just put the disclaimer up so I can read it for everybody? But Tony is a patient representative, and Rika is our administrative person who kind of helps run these meetings for us. So these PACE meetings, we have just certain rules for these meetings so that everybody is aware. So only patients and caregivers are allowed to participate in these meetings. So these are kind of not open to public or anybody, but only for patients and caregivers. So you feel comfortable asking questions. This event is not to obtain, solicit, or share medical advice, but only for general education purposes. And this event does not and cannot relate to care provided by kidney doctors, by your own doctors, and for individual health or kidney-related questions, please speak to your own doctor. Well, with the disclaimer, today we are going to talk about FSGS because June 10th is the FSGS Awareness Day, and this month in general, June is the FSGS Awareness Month. So we'll focus on FSGS today. How we do these conferences or these meetings is that I will start with a little bit of a presentation just to talk about a particular disease or a topic for about 10 minutes or so, and then we'll take questions after that. And that's what Tony was saying. Feel free to put in questions if they come, and she'll be the person, the representative, to kind of read those questions, and then I'll try to answer the questions to the best of my ability as I can. With that, it tells me I cannot share. So I don't know, Rika, if you, oh, now I guess I can. Screens. Okay, thanks, Rika. I think now that I'm the co-host, I can share the screen. Let's see. Okay, so like I said, continue to share. Okay, we'll talk a little bit about FSGS, just what it is, a little bit basics of the treatment so that you can understand a little bit if you have FSGS. Probably you know already about it, but a little bit more understanding of the FSGS. So most of the content that I have here is from this guidelines, which is an international guidelines, which is called as Kidney Disease Improving Global Outcomes organization that gives guidelines to nephrologists all over the world about how to treat kidney diseases. These are recommendations given by a group of experts to the nephrologists. So based on either that's data or the studies that are out there or their expert opinions. And then it's up to the nephrologist how they take care of these patients, of their own patients, but primarily hopefully following these guidelines. These are for the nephrologist, so for the doctor. So I'll try to kind of make them a little bit more understandable for the patients and kind of take some of the details out, but still keep the pertinent information as we talk about this. Okay, so what is FSGS? FSGS is focal segmental glomerulosclerosis. So in our kidney, we have this is our kidney in the middle. Here we have two of these kidneys, all of us, and each kidney has about 1 million of what we call as nephrons. Nephrons are these working units in our body. We are born with about 1 million of each, and that's all we get. As we get older, after about 25 years of or so, then we start losing these nephrons. That's just called as age-related decline in our kidney function. All of us get it as we get older. But in people who have kidney disease, they lose more of these nephrons, and that's why you lose more of the kidney function. That those nephrons has that initial, and this is the cartoon portion of the cartoon kind of that glomeruli or nephron. So in the nephron, that initial part of the nephron is called as glomeruli, and though these are the glomeruli. These are like this is a 3D structure. So this is a cut section of that glomeruli. These are like ball-shaped structures, which have these tiny, tiny blood vessels, which are very fragile within this glomeruli, and they form a whole big network of these blood vessels. And this is where actually the filtering of the blood happens. And we form what we call as the pre-urine in this yellow space on the outside. And then it goes down into these long tubes in the kidney and then finally forms the urine. So what happens in the FSGS, a focal segmental glomerulosclerosis, that some part of this nephron, that's the segment, so small segment of these of these glomeruli, gets scarred. And as you can see in this diagram, this is this part of the glomeruli that is scarred. The cells around the blood vessels get scarred. The blood vessels again eventually die and get scarred, and then there is no filtering happening. Before, at the same time in the beginning, before the filtering stops completely, there's a lot of protein loss just because the cells outside are damaged as well, which help keep the protein in the blood. And so one of the things that happen is that because of the scarring, there is loss of kidney function, but there's also a lot of protein loss in the urine. This is again just a cartoon of one of those capillaries. So we're just looking into very detailed microscopic version of one of those capillaries or blood vessels where the filtering usually happens. So this round structure is one blood vessel, and this is the inside of the blood vessel where the blood is. The blood cells and the liquid in the blood as well. This yellow cell is what we call as the cell of the blood of the capillary, which is the cells which can be damaged in certain other diseases, kidney diseases. But this green cell is the main cell in FSGS, which gets damaged. And these are called as podocytes. These podocytes have these foot processes, these very nice green kind of pathologists tend to call them foot processes, and they should be lining the entire capillary. These processes have a negative charge on them, and the protein in a blood also has a negative charge, and so it repels and it does not let those proteins come out into the urine from inside of the blood where the blood is in these blood vessels. So in FSGS and also in another disease called as minimal change, both these diseases, these green foot processes get damaged, and hence the protein leaks into the urinary space or the urine. And that's the first pathognomic sign of FSGS. Over time, these cells die, this blood vessels kind of dies and gets scarred, and then you can't have even any blood filtering, and that's when the toxins build up and the creatinine goes up in the blood. I did want to put a picture. This is what actually your kidney, if you had a biopsy of your kidney and you took a sample of the kidney and the pathologist stain it and look it under the microscope, this is what FSGS looks like under the microscope. So this part of the glomeruli, that cartoon that we saw, the round structure, this part is normal. You can see that's one capillary, which we saw. These are really open, very nice looking, thin blood vessels. And this is probably one of the outside cells, the green cells we were talking about, podocytes. This area, you'll see it's not the normal looking. There are no open blood vessels. There's this scarring that is there, and that's the segmental sclerosis, and hence it's only focal, and that's what we call as FSGS. So how do you diagnose FSGS? So you do some blood tests to assess the kidney function, which is your serum creatinine or serum cystatin C. Based on those two numbers, either or combined, we calculate something called as a EGFR, or estimated filtration rate of the blood by the kidney. Those are the most important blood tests your kidney doctor would do. Then the urine test that we do is looking for protein in the urine, or how much protein is in the urine. And that is doing a urine protein to creatinine ratio, or doing a 24-hour urine protein that you collect all the urine in the 24 hours and send that for the protein testing. But the final, the diagnostic, or what we call as gold standard, the only way to confirm the diagnosis is by doing the kidney biopsy, which is taking a small sample out of your kidney through a needle, and then putting it on a slide, and then staining it with a lot of stains, and then looking under the microscope. And it kind of looks like we saw that pink slide a little while ago. That's kind of what FSGS looks like when you look under the microscope. So now coming to how to treat FSGS, and I'll divide the treatment into two basic things. One is what we call as immunosuppressive treatment, where you're suppressing the immune system to cause decreased damage to the podocytes, or those green cells that we saw on the kidney. And the second is just managing the effects of the damage that's already been done. And that's what we call that decreasing the effects of the protein in the urine, or to decrease the protein in the urine. And these are general treatment guidelines to help decrease the protein in the urine, managing high blood pressure, and managing edema that happens to come with protein in the urine. And the first one comes through lifestyle modifications, and that's really important because a lot of patients ask that what can they do themselves to help their kidneys and help stay healthy. And this is one of the things, and few of the things that you could do by yourself. And it comes again and again. But one of the most important thing is changes in the diet. And if I had to pick one thing in the diet, that would be restricting your sodium or salt. When you think about sodium, it would be less than 2,000 milligrams per day, or that's the salt, or decreasing the salt. That's what is listed on the back of the product label. When you look at the amount of salt, is listed as sodium, amount of sodium in the food. The other thing that you could do is increasing the physical activity and staying physically active. If you do smoking cessation helps your kidneys, and reducing alcohol consumption helps in keeping kidneys healthy as well. If you do have edema, what helps with the swelling in the legs is or your belly also is sodium restriction, because that edema is water, but it comes with the sodium. So wherever in a body the sodium goes, the water goes. So if you eat less sodium, your kidneys have to get rid of less sodium, and it does not retain in your body, and that helps in decreasing the edema. Sometimes doctors use what we call as water pills, or known as diuretics, that essentially help you again pee out the sodium. Is what the main goal of those water pills is. And with that sodium will come the water, and that's why you'll see an increase in the amount of urine that you urinate with those water pills. And when you are on these water pills or diuretics, then you would need a little bit more blood test monitoring of the electrolytes, some of the electrolytes, as well as kidney function by creatinine as well. Now going to what decreases the proteinuria, which are these general kind of general interventions that will help decrease proteinuria. Again, low salt intake or low sodium intake by itself decreases edema, helps the kidneys, but also helps decrease protein in the urine, whatever be the cause of protein in the urine, either FSGS or any other cause as well. Good blood pressure control. So getting your blood pressure low helps decrease the protein in the urine, because there's less blood pressure in the kidney that helps decrease the protein in the urine. Our goal is usually about less than 120 over 80 millimeters per mercury, if we can get there. And sometimes it's really hard to get there. Among the blood pressure medicines that we use is the blood pressure medication, this class of drugs called as ACE inhibitors, or ARBs, which are the two most common medications in the United States available are lisinopril and losartan in the two categories. But there is a lot of other medications, but they all end in pril or artan. And those are the medications that blood pressure medication that help in decreasing the protein in the urine. And are much helpful for your kidneys compared to all the different other blood pressure medicines that are available. Then the second class of medications, which is a much newer medication that is available or just helps decrease the protein in the urine, is this new class called as SGLT2 inhibitors, or sodium glucose transporter inhibitor. The two most common medications that we use for kidneys in this class of drugs is called as dapagliflozin and empagliflozin. They are a weak diuretic or a weak water pill as well, along with helping decrease the protein in the urine. So that would be the next medication that I would use to help decrease protein in the urine after the ACE inhibitor or ARB. Then the third medication that helps decrease protein in the urine is called as spironolactone, which is also a water pill, but helps decrease protein in the urine, and works a little bit differently than the SGLT2 inhibitor. Obviously, the other things that decrease protein in the urine is smoking cessation. We talked about that before. And then if you are obese or overweight, getting to your ideal body weight helps decrease the pressure in the kidneys and decrease protein in the urine as well. The other things that can happen when you have a lot of protein in the urine is your cholesterol could go really high, and so your doctor would check a cholesterol level as well, and might start a statin like simvastatin or torvastatin to help manage that cholesterol. And then the other thing that happens, it increases the risk of blood clots. And sometimes if you do get a blood clot, then you might need a blood thinner until the protein in the urine gets better. There is a higher risk of infections as well because of this protein in the urine. When you have a huge amount of protein in the urine, you also lose other proteins in the blood that help you fight infections like antibodies, and that increases the risk of infection. So it's recommended that everyone should get a vaccine to help prevent those infections as well, because infections can in turn cause a flare of the FSGS as well. So this is kind of like the final, when we think about somebody who has a FSGS, then we talk about immunosuppression would be the next thing after these. Who to give immunosuppression is the one of the most important things to figure out for a kidney doctor when the biopsy comes as FSGS is, would my patient need immunosuppression or not? Because these immunosuppressive medications have a lot of side effects as well. So somebody who has a large amount of protein in the urine, which is about that number is more than 3.5 grams per day, we call that as nephrotic syndrome. And with that large amount of protein in the urine, if you do have low protein in the blood, and edema, which means swelling in the legs. And there's certain specific markers on the biopsy as well, which point all towards what we call as primary FSGS. So I'm on this side of this diagram. Again, you don't need to go into details of it, but if you do have a lot of protein in the urine, if their protein levels in the blood are low and they have swelling in the legs, those are more likely to have primary FSGS. And those are the ones that we consider treating with immunosuppressive medications, compared to somebody who has more than 3.5 grams. So they still have a lot of protein in the urine, but their protein in the blood is normal, or they don't have edema. Then we think that this is more likely to be secondary FSGS. Again, in medicine, it's not like it's always black and white, and there's always an overlap. Sometimes there could be features of primary, but they're secondary, and there's features of secondary, and they might have primary FSGS. So there's always an overlap, but these are the general kind of guidelines that they would be that person who has normal protein levels in the blood and no edema, they're more likely to have secondary FSGS. And in those people, I would look for more secondary FSGS and would think twice about starting immunosuppressants because they have a lot of side effects. It is recommended. There's a lot of other secondary things that can cause FSGS, and usually a lot of viral infections, sometimes medications. Those are the things that we would want to look at to look for any specific causes that could be reversible for a cause of FSGS as well. And then obviously genetics can also, there's certain genetic mutations that have been linked to cause FSGS. And they could be because it runs in the family, or the person would be the first one to get a mutation as well, which is what we call as sporadic. And so there's certain criteria that if they're not responding to immunosuppression, or if it looks like more secondary, then we would, or if they have a family history of kidney disease, those are the people that I would start with the genetic testing even before starting immunosuppressants as well. Which is when we think about, let's say, if somebody, I think that it is primary FSGS, and that's what I think they have primary FSGS, then which immunosuppressant to use is steroids or prednisone. And that is kind of the mainstay of the medication or immunosuppressant to use. We do use high dose of prednisone. That's the most common most common steroid that we use, prednisone. And it is needed for prolonged periods. At least more than 16 weeks is what it is recommended before saying that somebody is responding or not responding to steroids. Some people tend to respond much sooner, and that's what we call a steroid responsive, meaning that protein in the urine improves with the steroids. However, there is some people who it would improve, the protein in the urine would improve, and as we decrease the dose of the steroid, then the protein goes up again, and those are what we call as steroid dependent, that they always need a certain dose of steroids to be able to keep the protein in the urine away, and that's the subgroup steroid dependent. And then there is this subgroup, what we call as steroid resistant, when that protein in the urine does not improve with any of the steroids or any dose of the steroids, even with high dose steroids, for prolonged periods of up to 4 months. And obviously, steroids have a lot of side effects. For those who have been on steroids, they know that, but they have a lot of side effects, especially if you've been using a high dose for a prolonged period as long as 3 to 4 months. And it's not recommended to use it for prolonged periods beyond 6 months, and should be another medication added if somebody has been on steroids for more than 6 months to be able to decrease the dose of steroids. And that the most commonly, or the first line drug that is recommended by the guidelines is as a group of drugs called as calcineurin inhibitors, and the two most common medications in that group of drugs is tacrolimus or cyclosporin. And the goal of adding this is to decrease that protein in the urine to be able to get and be able to decrease the dose of steroids while on these. And then after that, if there isn't a lot of data among other medications that would work for FSGS, there are a lot of other immunosuppressants that nephrologists use for treatment of FSGS, like mycophenolate, like rituximab, but there isn't a whole lot of data supporting that, and guidelines recommend, at least the KDIGO guidelines recommend, that would be an individual kind of basis that you would try those medications. Then the third thing would be for FSGS would be a lot of clinical trials. Again, there's not a lot of clinical trials in this realm, but there are definitely new ones starting, and that would be one of the other things to consider or look for, is if there are any newer medications that are coming, to consider enrollment in a clinical trial, and to talk to your kidney doctor about that as well. But I did want to mention our website called as kidneydisease.org, which is where a lot of, as you can see, they have a lot of topics, which we call as kidney topics. And if you go, there would be other topics about kidney diseases that there would be. They also have a clinical trials portal where some of the clinical trials with kidney diseases that are actively enrolling, there's a list of those. And then there's also a list of the patient care and caregiver engagement, these conferences, the new ones coming as well in the next couple of months, if you want to look at those as well. And like I said, there's a list of clinical trials that are there, which are currently enrolling. The other place to look at the clinical trials is this clinicaltrials.gov website, which has all the clinical trials that have been previously done, that are actively enrolling, or that have enrolled and still continuing, and we're waiting for the results. So and you can put in the condition or the disease, because all clinical trials have to be it by in a university, be it by a pharmaceutical company, be it sponsored by the NIH, whatever, wherever the trials is being done, they have to enroll into clinicaltrials.gov. And so you can put in the condition of the disease. So we're talking about FSGS, you can put that, and then you can put in all the studies, you can put in location closer to you or what the intervention is done, and then it will give you a list of those that are done. So if you look at FSGS, if you I put in, and there were 107 studies, and then you can kind of narrow whichever you want. So this is about one versus FSGS, and there will be details of that particular study if you go into that. So that's one of the ways to look for new clinical trials if you're looking as well. So just summarizing or take-home points, a kidney biopsy is needed to diagnose FSGS. steroids or prednisone remain the mainstay of the treatment if somebody has primary FSGS, where they would need immunosuppressants. And non-immunosuppressive treatment is as important and or even more important sometimes for treatment of FSGS, which includes controlling blood pressure, low salt diet, and medications that help decrease the protein in the urine as well. And that is all I had. And I'm going to stop sharing now and we will do some questions.
Okay, so one of the questions is spirolactone harmful to the
Mm-hmm.
kidneys?
Mm-hmm. So, spironolactone is actually not harmful to kidneys. It is a water pill. It helps get rid of the swelling. It's not a very strong water pill, but it's one of those water pills that helps decrease protein in the urine. So it's one of the preferred sometimes water pill to help get rid of the fluid if you have not a lot of edema, because it helps decrease protein in the urine. Any water pill can sometimes cause damage to the kidneys just because it can make you a little bit dehydrated if you're not eating and drinking okay. Or if it mixes with other medications like ibuprofen or some of the ones that I mentioned, ACE inhibitors or SGLT2. So it by itself is not harmful, but in certain conditions, if you do get dehydrated, then it can make you more dehydrated, and then it can cause damage to the kidneys.
Mm,
So
okay,
you just have to be careful. As any medications, every medication has side effects. So as some of the much stronger water pills like furosemide, that's the most commonly used to get rid, and that sometimes can cause damage, but eventually it helps in getting rid of that swelling as well. So.
right,
But if you ask me a question directly, if I had to pick yes and no, it would be definitely for sure that it is not harmful. It's actually helpful for the kidneys.
right. Okay. Another question is, when someone has primary FSGS and has relapsed first time following prednisone, at what point should medical intervention begin to reduce proteinuria? And what course of treatment would be likely if prednisone was not tolerated well by the patient?
Yeah, that's a good question, a very good question about when they have relapsed following prednisone. So that's kind of what happens as to guidelines are not very clear what is recommended by the guidelines, and then that's where it comes into the shared decision making with your kidney doctor. Usually, it is recommended if you go into relapse, and this is again, I'm talking about then expert opinions. Telling the nephrologist to do this because there's a lot of studies. But if you've relapsed once and you've been on a high dose of steroids for about 4 months, it gets hard to do the long course of steroids again, and that would be because of the side effects, as you mentioned. They accumulate over time, and that would be recommended to do a steroid sparing therapy at that time. And the first line steroid sparing therapy would be a calcineurin inhibitor, which would be a tacrolimus or cyclosporin at that time. Again, there's some contraindications of every medication, so that would have to be looked as well if they can tolerate those medications or not. But if they've relapsed, that might be a time to consider, depending on how well they tolerated the prednisone or not. Some kidney doctors, I know it's not as clear that I can say for sure. Some kidney doctors like to do prednisone again, especially if the person tolerated prednisone well for the first time and if they responded really well to the prednisone. Those are the people that even I might do prednisone for the second time, because if they responded well, they tolerated it well, it might be worthwhile to do it. Because once you start calcineurin inhibitors, that's TAC or cyclosporin, you are on it for at least 1 to 2 years or even longer to get to keep someone in remission for that long. So it's one of those even longer term medications that it would be.
Hmm.
Does that
Okay.
answer the question or yeah?
Well, the other question was, I don't know, it's almost similar. Is I have primary FSGS and recently relapsed for the first time. I've been put back on 15 milligrams of prednisone and they added 1.5 of tacrolimus twice a day. I'm wondering how long it normally takes us to start seeing a reduction in the proteinuria, and also could I see full remission from the medication plan?
So, like I said in the beginning, usually we try not to do personal because
Right.
recommendations because it's really hard for me to know everything. So this is more for education purposes. So I can't say how long it will take, but in general, people once you start somebody on tacrolimus, every person is different, but in general, it takes about at least 4 to 8 weeks to help get into to see the improvement in the proteinuria. And that's why sometimes people like to overlap because prednisone decreases the proteinuria much faster than tacrolimus, which takes a little bit longer. And to get into remission, it might take up to 3 to 4 months with the calcineurin inhibitors to completely decrease the proteinuria, or even longer sometimes. So prednisone does work much faster in decreasing the protein in the urine. Does
Okay.
that kind of answer, Tony? Would
Yeah,
you? Yeah.
pretty much. Yeah. Okay, here's another question. Is it possible for tip variant patients to get into complete remission?
So that's a good question. So tip variant is just for everybody knows there are, when you look at that FSGS on that pink slide I showed, that's the pathologists can look at different types of FSGS, and there are about 6 types, and one of them is called as tip variant. Um, and there isn't a whole lot of data that says that when you see certain pathology, then it would improve, it would respond better or not. And it's not correlated as good as to those who respond or not. But usually, tip variant is one of those variants that tends to respond really well to steroids. Classically, although I've seen patients with tip variant who don't respond as well. Again, it also depends on which part of the kidney you biopsy because you're taking probably not more than 20 to 30 glomeruli. So maybe other ones don't have tip variant compared to the ones you got. So it's very variable. And that's one of the difficulties with FSGS, and that's why there's not a lot of studies because it's a very heterogeneous disease, and it's really hard to study as well because they're very people present very differently. But again, tip variant is classically thought to be one of those that responds really well among all the FSGS types that there are. Does that kind of?
Hmm. Yeah. Okay, so there is another question about sharing the biopsy or sending it to another address. I'm not sure exactly what,
Yeah, so that is a good point as to if you can send your biopsy to another pathologist. So just to clarify, the biopsy is read by a pathologist, which is a renal pathologist. A pathologist get so you have you do your medical school, then you do a residency in pathology, and then you need another training to read specific kidney biopsies, and those are called as renal pathologists. And so they're not read by the nephrologist who's seeing you in the clinic, they're read by a pathologist. So your own nephrologist can send those biopsies, and I do that sometimes if they got a biopsy somewhere else and they're coming to see me now in my clinic. I might have them I might have my clinic get the slides and read by my pathologist who I can talk to because sometimes you get a lot more information when I can review the slides with the pathologist. I can't read the slides. I'm not trained to be a pathologist because I'm a nephrologist, but personally reviewing the slides helps me understand a lot more. So you can definitely get a second opinion. Most of the time, the way to get it done is through the kidney doctor and their clinic, who you are seeing in the clinic, and they will reach out to where you got the biopsy, who read it, and they can coordinate that part as well.
yeah, good answer. Okay, and here's another question. What is your experience with rituximab for kids?
Yeah, so that's a good question again, because I think one of the areas in FSGS that's been studied, especially for kids, rituximab has been studied and has shown that people who are steroid resistant FSGS, rituximab is one of the options that helps decrease the protein in the urine. I don't treat kids, and I only see adults with nephrotic syndrome and FSGS. So I can't say my experience with the kids, but the studies that I've read and my colleagues who are pediatric nephrologists use rituximab quite a bit to help treat, especially those who are steroid resistant or steroid dependent. and who have been either on calcineurin inhibitors for a while or cannot tolerate the calcineurin inhibitors. But usually for FSGS, both the guidelines in adults and peds do not recommend that as your second line. So not after the steroids, but those who cannot be on CNI, which is tacrolimus or calcineurin, or have been on it and still relapsing, or have been on it and cannot get off of it, that's when I would use rituximab.
Okay, so full remission is possible with that.
Definitely, yes.
Okay,
Yes,
okay.
it definitely could be.
Let's see, and there was another question here. Oh, Actar gel. Have you seen results with Actar gel for primary FSGS?
I have not used Actar gel for primary FSGS, and I haven't seen myself, but there is some data out there that it does work. It is that Actar gel uh, it contains a hormone which is ACTH, and what that does, it makes the production of increases the production of the steroid that we do the prednisone in our body. So it essentially increases the steroids in our body by our adrenal gland where they're made. So in our body, we all have ACTH, which is the Actar gel, which is released in our brain by the pituitary, and then it stimulates our adrenal gland to produce steroids. And so instead of doing the steroids, you're trying to give a little bit upper stream medication, but they do get side effects very similar to steroids, maybe a little bit less because it does not increase the dose as much. There is some data that people say that our kidney cells, those cells that we saw, those green cells which are damaged in FSGS, they also have the receptor for Actar or ACTH, and that might have some additional advantage over just the steroids. But primarily it is the steroid effect with maybe an additional effect on the top of that.
Okay. So I was looking at another question here.
Mhm.
It was saying that I need a second opinion, but don't have insurance. Is there resources for that?
Yeah, I can answer, and then maybe if Dr. Poyanmer wants to answer as well, he's on this call as well. So usually it's very dependent if you don't have an insurance as to which your closest medical, where you're living, and which is the closest medical system that there would be. I sometimes see patients in my clinic, those who don't have insurance, and I'm in with University of Wisconsin-Madison, and our hospital has resources as well to help see those patients where they do get patient assistance, and I usually get my social work involved at that time. So those are the most resources that I know would be locally available in each hospital system or each kind of I would say state or city in that particular area that I would know of. I don't know if there is anything more that I know at a bigger level that there would be. I don't know, Dr. Poinmer, if you want to add something to it, but that's kind of how I do it when I get patients who don't have insurance. But I've seen them in my clinic as well.
Okay.
Okay.
Um, Here is another one. Let's see. Can tacrolimus taken for lifetime to sustain remission?
Yeah.
And, that's also like a transplant drug too. So,
Yeah.
transplant patients also take that pretty much for life.
Yeah.
So,
So a great point, Tony, and that's what I talk to my patients too. And how long can you take a medicine? So once you've been on tacrolimus for 5 years, that's kind of okay. And then beyond 5 years, when you start seeing those cumulative side effects, which is what we see in transplant patients, and it's much more well described in transplant patients because, like you're saying, anybody who has a kidney transplant needs to be on tacrolimus for lifelong or until that kidney is working, right, for the rest of the life of the kidney. So you definitely can be on tacrolimus for a prolonged time because people have been, and I've seen people who have been on it for 20 years. You do get those cumulative side effects of it. So usually, I do tend to start tapering it really slowly with the aim of hopefully getting them off at some point of time, because there's no way to know that if you would relapse or not until you slowly taper it off. And that's the difference between having a kidney transplant versus your own primary kidney disease, because that gives you that possibly an ability to be able to get rid of, to be able to taper off the medications. And yes, we don't cure FSGS, but we can treat those flares. And typically, we treat a flare for about 3 years. And then in that time, we'll slowly taper off and try to get you off. Again, people can flare again. If you flare right away as we taper off, then you're the one who needs it for much longer, possibly, or might need it for prolonged periods of the tacrolimus. If you're being able to get off of tacrolimus for 5 years and then flare again after 5 years, I think it's reasonable that you were able to stay off that medication for five years in between and get that gap, right? Or even 2 years and get that gap in the side effects that you might get otherwise. But I totally hear the apprehension, because it's really hard when you get the flare. And every time you get a flare, I also worry that you lose some of the kidney function as well, along with the symptoms and all the other things that are very hard to manage as well. But you lose the life of the kidney as well every time you get a flare. So it's that balance between the two, and sometimes we go really, really slow and decreasing 0.5 by every couple months, or depending on how this previously you have relapsed or not. Now, going into side effects, I know I've mentioned the side effects of tacrolimus. Usually, we don't worry of much side effects for the first 5 years, but once you've been on it for more than 5 or 10 years, it by itself can cause some scarring in the kidney. So that's one of the things. But again, if you can prevent one flare, sometimes that's enough, because one flare might be enough to cause by itself a lot of scarring, and maybe it's better to stay on tacrolimus. But the other thing that happens with the tacrolimus, which I worry more, is diabetes. So especially as you get older and you get into your 40s or 50s, or even later, the tacrolimus by itself can and cause or predispose you to have diabetes and high cholesterol as well. And that's one of obviously, usually you don't see it in the first, second, third year, but it's by third or fourth and fifth year that's when we start seeing those effects as well. It's way more, it's a lot more described in transplant patients, because they have been on it for a prolonged time. And that's why what we call that is post-transplant diabetes sometimes, but it's the tacrolimus that changes the metabolic profile in our body and predisposes to diabetes and high cholesterol levels, which in turn increases the risk of heart disease as well.
Right.
So it's just
Okay.
the balance of the two that you would have to worry. But yes, can you take it? You definitely can be on some medications. And if it's these side effects that I was talking are very dose dependent. So if you can be on the lower the dose, the better it is. So the lowest dose possible to be able to stay in remission would be the one which would be recommended.
Okay. Okay, here's another question that came through. What is this? Is this Gazva? I
Mm-hmm.
look at that as,
Yeah.
is that the same thing as Obinsamab?
Obinutuzumab, yeah.
Right. Okay.
It's obinutuzumab.
Yeah. Is that a good option for primary FSGS? And somebody said they had partial remission after 3 months of treatment or
Um,
rituximab treatment.
So again, I can't say for this specific person again, because it's not possible for me to give a personal advice. But in
Right.
general, people who have not responded fully to rituximab, sometimes we do use obinutuzumab, because it depletes so rituximab kills a specific type of cells in a body called as B lymphocytes, and obinutuzumab or Gazyva kills the same cells, but a little bit but is much stronger in a way, is what I would say. It kills in a different mechanism, but causes much deeper depletion, or is much stronger. And so sometimes if you have responded partially, meaning it is working, but maybe you need something stronger to get rid of the B cells completely, then that's what we use. And sometimes in some people it does help to be able to get that. Yeah. And there's some data in literature about some definitely case reports as well that obinutuzumab does work in FSGS as well.
Okay. So I guess my question would be, let's just say, have you seen like patients go, instead of doing rituximab, they just do the other one first? Or
Obinutuzumab. Yeah.
yeah, or do you actually have to do retux and then the other one?
That's a good question, Tony. So it is a newer drug, at least in nephrology field. It's been in both rituximab and obinutuzumab, that's Gazyva, came from lymphoma, and they're still used for lymphoma treatment, which is the chronic type of lymphoma. So this is a newer drug in nephrology field and still has not been studied as first line,
Mhm.
or like instead of rituximab, at least in FSGS. It's been studied in some other diseases like lupus nephritis, and I used now this in lupus nephritis instead of rituximab. I don't use rituximab, especially obviously if the insurance gives it, but
Mhm.
approves it. But because it does work better than rituximab, again, it is a much stronger immunosuppressant. So you do have that higher risk of infections, a little bit higher than rituximab, is what I see. The major infection being shingles, just because it reactivates, that zoster virus reactivates, both with rituximab and obinutuzumab, but a little bit more with obinutuzumab. Again, just saying that it's much stronger immunosuppressant, but haven't used this first line as or I should, when I say first line, but not before rituximab in FSGS. But maybe, um, again, I think usually in medicine we'll start using it as if people are resistant to certain, and then if we see improved response, maybe then in the next time we'll use it again, just because we don't know if it would work better or not as yet, but has more side effects.
Well, that's good to know.
But definitely there are more options coming, which is a good thing, which is very exciting in FSGS, than just the previous, which was steroids alone and prednisone for the longest time. And then it's like tacrolimus or cyclosporin, and now we have rituximab, obinutuzumab. Obviously, mycophenolate is always there, which may or may not work. But there are other newer medications, like sparsentan, which helps decrease the protein in the urine. There are other medications that are being studied as well. This group of medications called as ET2 receptors or endothelin receptors. Again, endothelin is one of the molecules in our kidney, and once you block it, then there's decreased scarring in the kidney. So that helps decrease scarring in the kidney. So not the autoimmune side, but it helps decrease the scarring, and that helps as well.
Interesting. Yeah, it just seems like there's so much more treatments coming out compared to the last 10 years. It's
Definitely.
yeah, so that's really good. Um, I guess this is another question, another one. It says, can you restart prednisone after coming off of it after not seeing improvement?
I guess if somebody has been on prednisone, and that means if I say somebody is steroid resistant,
Hmm.
but for me to say somebody is steroid resistant, I want them to be on high dose of prednisone, which is a more 60 milligrams or more, daily dose for more than 16 weeks, 4 months, before I call them steroid resistant. If you've not been on this prolonged duration and this high dose of prednisone for 4 months, I would not call you prednisone resistant, and I would still give you prednisone again if you flare. Um, but if in the past you've been on this more than 4 months of prednisone and still not improved, then I would not give you, because then you're not going to improve again, and then it's just taking the side effects and it's totally not worthwhile then. Because if you are steroid resistant once, then those are steroid resistant kind of always. It's not that it changes with time. Sometimes I know it's not always all black and white, but sometimes people who are steroid resistant and they go into partial remission with some of the other medication, and they need a little bit more improvement, you can try a lower dose of prednisone to see if you can get into full remission on the top of that. So but usually people who are steroid resistant once, but you really need to make sure before calling someone steroid resistant that you've been on that high dose for at least 4 months. They tend not to respond to prednisone at all, and I wouldn't give them steroids again.
Yeah, I guess it's kind of like tailored to everyone. Everyone's different. So,
Yes, and that's the hard part sometimes in the diseases when they're so
mhm.
heterogeneous, it's to study them, and then that's why it's taken so long to for us to get the the medications approved for this because it's really hard to study and show the improvement as well. But those are the people, you're steroid resistant, those are the people I really send for genetic testing, because then there's a higher chance. And we didn't talk about genetics so much today, but those are the people who had the higher chance of having a genetic mutation. So about 30% of people, so 1 in 3 person who's steroid resistant will have a genetic mutation that's causing that FSGS. And having a genetic mutation, and that's one of the keys, is having the genetic mutation that's causing FSGS does not, I wouldn't say that I wouldn't give them immunosuppressants. I might still give them immunosuppressants for certain types of genetic mutations because they do still respond, because otherwise we have no other treatment for genetic causes of genetic. So sometimes they do respond to tacrolimus a little bit, and you can get them into partial remission and never into full remission. So it does not preclude, and that's one of the important things I wanted to bring, is like it does not preclude you taking immunosuppressants, but it helps you. One is to kind of plan, because it will help you look at other people with a similar mutation that have been described and see how long does it take for you to get into think about transplant. Again, not saying that that would be for everybody, but you get a mean and a median. Like, let's say mean is about 10 years. With this mutation, they progress to end-stage kidney disease. It's not that you will also 10 years, but it gives you a little bit an idea of how, because it's a lot different how mutations present. Same mutation might present in different people. And then the second, it also helps in trying to figure out who could be a donor, right? Especially if somebody's in your family, and getting your family members tested for mutation as well as family planning as well, when you think about planning family in future as well. So those are definitely the things, at least at this point of time, and maybe in future we'll have more directed treatment for people with specific mutations. And that helps in getting tested right now and seeing what you would respond to with this mutation.
Right. Okay. And here's another question right here that came through. What are your thoughts on lipid apheresis helping possibility with long-term remission?
So, well, lipid apheresis I've never used. Plasma
Mhm.
pheresis, which are kind of very similar, I would say, if that's the question. But lipid apheresis is removing your plasma because you want to remove the lipids. But I think for the most part, it's called plasma pheresis.
Mhm.
Lipid pheresis is just another name when you have high cholesterol, we say it. But plasma pheresis has mostly been studied in post-transplant recurrent FSGS. So if somebody has FSGS, it leads to end-stage kidney disease. They get a transplant, and FSGS can recur after transplant. And in those who recurs, that's the patient population. That's where it's been studied and shown some promise that it helps keeping FSGS in remission. Again, that probably is because among all the people with FSGS, those who recur might have something in their blood that's causing them. And so if you remove that, that helps. So now people have started using, which makes total sense, but it's really hard to find because we don't have a marker among all with FSGS as to who that person is before they get the transplant. So sometimes people use those who have really resistant FSGS, that as well, where you don't find a mutation, they're not responding to steroids, they're not responding to that. And then it's like there's nothing out there as to how long you can keep in remission when you start tapering the pheresis. I think that would be usually I would again I've seen mostly patients post-transplant when we are doing pheresis, because I also see post-transplant patients when they recur. And then after about 6 months to a year, we start tapering the plasmapheresis. So not every week. You start with 2 to 3 times a week, then going to once a week, then slowly tapering it again, because doing pheresis has a lot of side effects by itself. It's kind of like doing dialysis. You remove the whole blood, but it's even sometimes more intense. So again, we're talking about very, very rare portion of where there's kind of not much evidence to it, but definitely has been shown to work in very few people. And so sometimes we do try that, and it helps in maintaining remissions for sure.
Okay. I think those are all the questions for now. We kind of like at 10:25.
I know we kind of went over a
We
lot of
went over a lot of
yeah,
good questions.
yes today.
Okay. So the next one is going to be the second week of July, right? So
Second week of July, which is, I think, if I'm looking at the date, so that would be
July
the,
13th?
yeah,
Yep.
July 13th.
Okay. So we were in the talks about what we should do in the next other
Mm-hmm.
subjects. So we talked about maybe having someone for genetics, like a guest
Yeah.
speaker, and
Mhm.
then have another guest speaker for pathology, another guest speaker for clinical trials. So this will be very exciting to have them on here because I wondered about, the biopsy. What does this mean? What does
Yeah.
that mean? So that's I don't know when we're going to do it, but sometime within this year. And
Yeah,
then
those three,
yeah,
and maybe a diet. Those four we were thinking. We've had dietitians before, but it would be good because that's also one of those most frequently asked questions. Those
all
four,
right.
yes, probably.
Yeah.
Yeah.
Okay. So I guess that would be it. Thank you so much, Tripti,
Yeah.
for this, for answering all these questions and your time.
Definitely. Yeah. And again, if you guys have any other suggestions as to what topics we can cover or whom else will help you kind of with this, just email or put it on the website. There is a feedback page. You can put it there, or you can put it on the comments as well for this talk, and we can look at there.
Hmm.
But yeah, thank you, Tony, for being here and
Yeah,
moderating this and being a partner in this.
sure.
It's always fun. Okay, well, we'll see you guys on in a month from now on July
Sounds good.
13th.
Okay.
Take care. Bye bye, everybody.
Bye, guys.